Started. So thank you everyone for joining us for this month's CTSC Distinguished Speaker Series. I just want to take a moment to introduce our speaker for today. So Dane Christiansen has worked in government relations since 2004. He specializes in advancing medical research, treatment development, and patient access related to policy goals for a variety of stakeholders within the professional community. He has a background in grassroots organizing and healthcare advocacy, as well as a detailed understanding of the federal budget and appropriations process. Dane holds a BS in political science with a concentration in economics from Marietta College. And he also holds a certificate in leadership from the Bernard McDonough Center for Leadership and Business Studies and an MBA in multi-sector healthcare management. Dane has represented the Coalition for Clinical and Translational Science for close to 15 years, where he's worked on the CTSA program and with many member institutions. And so with that, I will turn that over to you, Dane.
Thank you very much for that introduction. I was interested in this, of course, with being an alumni of Marietta. I'm familiar with Case Western and Cleveland and a bunch of the area, so I was appreciative of the invite, though I will say this is a chat that has been a little bit more common this year than it has been in years past, and I think part of that is a reflection of we're living in dynamic times when it comes to policymaking and uniquely dynamic times in the research enterprise. So I'm happy to provide an update. I'm going to talk a little bit about the 30,000 foot level, what's going on in Washington. I'm going to talk a little bit about the coalition's advocacy efforts. There's a couple of things I think should come through in this presentation, though. One is that, it's a very divisive and dynamic political environment. But of course, when it comes to legislation and policy making, that's a process. And the process is a process that is very dry, very well established, and very much enshrined in law, going back to the founding fathers and everything else. So I don't want to lose the forest from the tree, which is some of the, it seems like discord and rancor and change exists very much in kind of a PR arena. But then I also want to remember what's happening on the policy and legislative side as well. And of course, part of that policy and legislative side is that we have a representative government and a limited democracy. So your members of Congress are interested in hearing from you and always have been and always will be. And that is how they make decisions on these types of issues. So whether you think the country is moving in the right direction or the wrong direction, it is always a good time to connect with your senators and representatives, identify challenges and opportunities for them, let them know how they can be a helpful resource. This is how the process works. So regardless of what's coming out of the White House or what's posted on X or Twitter or anything else, your members of Congress will always be interested first and foremost in the information that you bring to them. So I hope that comes through as well. But my name is Dane Christiansen. I've been involved in research advocacy and grassroots work for decades, spanning a large swath of kind of moderate political work. And I think that's crucial because, of course, the issues that are divisive are the ones that get fought about every year. The issues that get addressed are the ones that are middle of the road because anything that gets done is going to require bipartisan support, House and Senate, et cetera, et cetera. But we're here today to primarily talk about the work of the Coalition for Clinical and Translational Science and what's happening on a policy front for research. The Coalition for Clinical and Translational Science, if you're not familiar or if you haven't been to the translational science meeting and the very large Hill Day that comes along with that, is a joint effort of the Association for Clinical and Translational Science and Clinical Research Forum, but it is a big tent. It is welcoming and open as a grassroots effort for anybody who cares about these issues and anybody who works to advance the full spectrum of research, from the initial young investigator to the most established Nobel Prize winning scientist. So in that regard, once again, your voice counts. But I'll do a little bit of background here on the CCTS. So this is a picture from the Capitol from our Hill Day. If you haven't been to a translational science meeting, it is when we go to the Hill. We do have to cap participation at about 250 people every year. But of course, those 250 people represent academic research centers across the country. They represent Ohio, they represent Michigan, they represent Florida, they represent Utah, and that allows us to speak with one unified voice and coalesce around issues of common concern. And it allows us to reach a lot of policymakers with a very strong message. We do have some specific priorities that I'll get into, but we encourage anybody to participate. We encourage you to advocate. Even if you can't make it to DC, you can always send messages to your members of Congress. You can meet with them locally. You can email their staff. You may already do this. And I don't want to step on any toes. I'll make it one thing very clear. I'm sure Case Western and other institutions have their own government affairs apparatus. Always a good idea to check in with them too. They might have some things that they think are timely and important. They might care about what you care about. And they also might have some insight on ways to approach these offices or things that might be helpful. But this is our event every year to represent the community. And of course, CCTS is devoted to advancing the full spectrum of medical research. And my work with CCTS goes back to when the CTSA program was basically established, and we started this whole switch over from the GCRC network. But I think folks might remember for a long time, the NIH said, we just do basic science. We are basic science all through and through. That's not the case anymore. There's more of an increasing appreciation of clinical and translational work, and of course, more of an appreciation by Capitol Hill that if the nation is investing taxpayer resources into the scientific enterprise, then there should be a reward for that. The reward isn't a published paper. The reward is information dissemination. The reward is changing in practice guidelines. The reward is new breakthroughs that lead to new therapies. And this is the clinical and translational piece. So it is a newer piece, but it is a very valuable one if you're a policymaker. You're not investing in research for the sake of getting a study published. You're investing in research because you expect it to do two things: support local academic research institutions and support your constituents who are patients with a variety of chronic, rare, serious, etc. conditions across the country. So why we advocate together as a grassroots network? What do we do? First and foremost, we educate senators and representatives, and we use our personal stories to inform this experience. This is not Mr. Smith Goes to Washington. You're not going to be sitting, as if you're in court being questioned about stuff. These offices, regardless of if they're Democrat, Republican, all the work we do is nonpartisan, want to hear from you. They need to know what's working for you, what isn't working for you, and that's how they make policy decisions. The best way to do that is with pure lived experience. This is what's going on locally information. A big way this was effective previously, of course, was with NIH pay lines. The NIH budget was stagnant for many years. Pay lines were getting, sub 10%. I believe they're 8% for a while. And people would come in and say, 1 in 12 grants getting funded just is not enough. And Congress responded by doubling the NIH budget. This was during the Clinton administration with a Republican Congress and the contract with America, but it was done in response to constituent outreach. So the best thing we can do is simply educate. What is clinical and translational science? How does it affect the health of the nation? How are those resources applied locally for infrastructure, jobs, progress, et cetera, et cetera? You use your personal story to raise awareness, whatever your journey has been, and you talk about those challenges and opportunities. If you're a young investigator and it's tough to get that first grant funded, what's going on? Is there not enough grants available? Is there something with the application process? All of this information is valuable. Your members of Congress and their staff are not experts in this area. They know that you're an expert, though, and they rely on that expertise to help inform their decisions. So the squeaky wheel very much does get the grease, but we use another expression as well, which is if you're not at the table, you're on the menu. So one thing to think about is if this is a competitive process and these members have lots of competing interests. If you aren't in there putting a marker down for yourself and the work you're doing, and somebody else is, who do you think they're more likely to help? They can't proactively figure out what your needs are. The system rewards those who participate in it. What we help with is asking for a specific action at the right time. Congress, of course, has a process they follow. Legislators have the power of the purse. So if they're deciding how much money is going to research funding, and you reach out to them in December and say, hey, we really need to invest more in medical research, they might say, well, geez, I wish you were here in February or March when we were making these decisions and not now when that process is largely over. So what people like me do is inform when your outreach is most effective and when and how you should do it to maximize that effect. But it's your voice and your story that matters. And by working together with things like that 250 person Hill Day, we gain a critical mass of support on Capitol Hill. It's not one member that has to carry the water on this. There are dozens of members across the political spectrum, senators and representatives that can all work together to create real progress. Of course, it's a system that relies on this critical mass of support. We are fortunate that we've colleagues all over the country that can speak with a similar voice and identify similar issues. So we coalesce around areas of common concern, and we highlight those things that might be unique to our community that Congress wouldn't otherwise know about. They very much want your input. And I want to make it clear too, there are narrow margins in the House and Senate, so they're listening to you. They don't want to alienate their constituents and feel like they're not working on your behalf. And of course, what we do is non-political and not partisan. And the staff people you talk to, particularly the health LAs in Washington, by law are not political or partisan either. They are there to do policy work. There's about every year, the American Academy for the Advancement of Science sends about 100 fellows to Capitol Hill, and the Robert Wood Johnson Foundation sends others. These people are subject matter experts. They're doctors, they're nurses, and they work in these offices as health legislative assistants. What they gain is learning how Congress works for 6 months or a year. And what the office gains is a staffer that has the unique technical experience of someone who's been to medical school or gone through nursing school. So they rely on that kind of information, but I want to make it clear, politics is everywhere, but this is more about process and more about policy. So data, information, honest facts, and direct identification of challenges and opportunities. So to be clear on the current CCTS legislative agenda, there are certain things that we coalesce around that are, I guess I would say, low-hanging fruit from an advocacy perspective. One, of course, is funding for the National Institutes of Health. The high tide raises all boats. So is NIH getting more money year over year? And is ARPA-H, the Advanced Research Projects Agency for Health, getting more money year over year? Congress every year is writing funding bills. They're deciding how much money goes to the FBI, how much goes to the Department of Agriculture, and how much goes to medical research. So, of course, if you want your members of Congress to prioritize NIH, which has always done pretty well, you need to ask them for that. But right now, there's a $400 million funding increase pending with the Senate. The Senate has that. It's not the biggest increase ever, and they can give even more in a final bill. But first and foremost, NIH needs meaningful funding increases. We have to invest in research. No one would say we're giving research too much money right now. Second, as you go down that org chart a little bit, is the National Center for Advancing Translational Sciences needs an increase, or NCATS. So we ask for increases, often proportional for individual institutes and centers. In NCATS, the National Institute of Minority Health and Health Disparities, and National Institute on General Medical Sciences. And there's a reason for this. Of course, clinical and translational research goes on across NIH, so the high tide does raise all boats to a certain extent. But we benefit from a few very specific programs as well. First and foremost is the CTSA program. Clinical and translational science wards have their own line item budget in the spending bill every year. They have their own allocation. Right now, it's $629.5 million. About a decade ago, it was more like 300 million. So the funding increases matter for expanding that CTSA network, and Congress can directly provide the amount of money that is needed to get there. When they originally outlined the program, though, years ago, they envisioned 60-ish centers at $750 million, and that's 15 years ago money. So they need to do more. They do the best that they can every year, but once again, needs more investment. The other thing that we keep close tabs on is the Institutional Development Awards at NIGMS. And this, I think, is an example of how politics plays into this, or kind of topics of the day. So IDEA, of course, and the clinical and translational research efforts there is meant to specifically benefit states that traditionally have not had all the research funding. Congress is very interested in rural care right now. So we advocate for funding increases for IDEA. And this year, Congress is proposing a $21 million increase. So the stars align. You ask for additional resources, you have this rural health push, and you see funding increases like that materialize. The other program that I'll mention is Research Centers in Minority Institutions, which is part of the National Institute on Minority Health and Health Disparities. We do also support other agencies across HHS. Just to name a few, the Centers for Disease Control and Prevention and their public health work, and the Agency for Healthcare Research and Quality. As some of you may know, ARC has been a little bit more politicized lately. It's not uncommon for the House to just zero out ARC funding and say, why do we even fund ARC? Can't NIH just do this work? Every year we've been educating them about why that's not the case. ARC is its own thing, ARPA-H is its own thing, and NIH is its own thing. And if you have technical expertise here, maybe your members of Congress want to hear that too. But they've never zeroed out ARC in the final bill, but sometimes the House has proposed zeroing it out altogether. But at the end of the day, they listen to their constituents and they usually maintain that ARC funding. CDC gets increases as well, but they've never been as large as the investments in medical research. There's a disconnect there, of course, where we're trying to develop an advanced science, but then with the rest of HHS, with HRSA and with CDC, where there's a public health piece, we haven't done nearly as well. So we might be getting to innovative treatments, but not helping patients get diagnosed or linking them to care. These are all things, of course, that the CCTS can provide unique perspective on. First and foremost, though, probably the CTSA program, followed closely by IDEA. We do have a statement of principles. We believe in a number of things, and this is our North Star. So folks might know there's been a policy debate recently that has to do with extending expiring Obamacare premium tax credits. So we had an election in November. This was a state and local election, not a big election, but the Democrats leaned heavily into the rising cost of healthcare and healthcare being first and foremost. A couple of things happened as a result of that election. The Democrats won big on this message. So right afterwards, they reopened the federal government after a very long shutdown. And then they said, we're going to work on healthcare cost, quality, and outcomes. And it wasn't just the Democrats who said that, the Republicans said it too. So what we had initially was two competing proposals. We had an all-Democrat proposal on affordability that said we're going to extend Obamacare premium tax credits. And we had an all-Republican proposal that said we're going to use a combination of healthcare savings accounts and some other stuff. There is no reason to wade into the political nature of that debate and say, I support the Democrat idea or I support the Republican idea. Rather, it's better to simply educate members about what the real issues are with patients. What are the current barriers to care and what makes it harder to treat folks and deal with their out-of-pocket costs? They are feeling mounting pressure, and when push comes to shove, they're not going to pick a Democrat or Republican solution. It's not a tug of war. The only thing they can pass is a middle of the road compromise that everybody agrees on. And of course, that compromise is going to be informed by health professionals with expertise in this specific area. They will do the politics, but they will rely on their constituents to help sort this out. So the things we care about in a research and patient care standpoint are agnostic and nonpartisan, and that's how we judge these different proposals moving forward. It's not which party proposes them, it's how well do they work in certain North Stars that guide our decision making. Is the physician-patient relationship preserved? Do patients have access to all products and all sites of care? Are we investing appropriately in public health and research, et cetera, et cetera? So I do think it's important to mention a brief history of the CTSA program before we move on. The CTSA program has been established for a number of years and then kind of was in its infancy and saw some modest funding increases. I want to point out how advocacy works. There are many years where the NIH was level funded, didn't get any additional money, but CTSAs and the CTSA program received funding increases from Congress. It is not as simple as we kind of float with the tide. They are directing money where they think it's important and when they're hearing about from constituents. They understand the value and importance of this program, but they understand the value and importance of it because their constituents and hubs in their area have told them about how much it matters, the size of the awards, the work that's going on, et cetera, et cetera. The program has seen meaningful funding increases, but I think people might appreciate the NIH does not usually have parts of its budget that are earmarked and says this $629 million is just for CTSAs. The NIH is used to getting a big pot of money from Congress and being told just spend it on whatever science you think is best. So for years, the NIH had asked Congress to remove the funding line so they could take the CTSA money and apply it to other stuff. And they didn't say this, but they meant a lot of basic research that they were more comfortable with. Congress every year rebuffed them and said, no, we're maintaining the silo of CTSA funding and what it's meant for, clinical and translational research and supporting the hubs. This is important because, of course, this money and this fight predates anything else that's going on now in science and fighting about funding and rules. So we are actually more protected in the CTSA program because of what's happened in the past and the fact that we have our own funding line and the program itself is written into law. So there are enhanced protections for CTSA resources that don't exist for other parts of the NIH budget. And that's probably a good transition to what's happening in Washington right now. So it last November, not November 2025, but November 2024, we had a presidential election. And this was a sea change election. So, a third of the Senate was up, all of the House of Representatives, and we saw a lot of turnover. There's about 70 new members of the House of Representatives that were elected. That's a lot out of 435, and about 10 new senators. But the people that were elected in the House were not just freshmen. This wasn't George Santos or someone who'd just been there for a couple years. It was the senior leadership, mainly the senior leadership in the Republican Party, that stepped aside. There was a woman named Kathy McMorris Rodgers from Washington who ran the Energy and Commerce Committee. She retired. There was a woman named Kay Granger from Texas who ran the Appropriations Committee. She retired. So you had a whole bunch of new members, and then you had members moving into leadership positions that were now open. I mention this because this is why education is so important. Are these 70 new members or these new folks in leadership familiar with the CTSA program? And this might even hit close to home, or even the work that you're doing in Ohio. And I say this because Ohio, of course, out of this process got two brand new senators. So how familiar are those senators? One of those senators is on the Health Committee, the Committee of Jurisdiction for NIH and healthcare issues. But that's why it matters to have this level of engagement. And Congress decided to outline a few things that they wanted to work on. The first was budget reconciliation. Budget reconciliation is a process that requires a simple majority to pass. It doesn't require bipartisanship like every other bill, but the rule is it has to only apply to taxing and spending money in a very narrow sense, and entitlement programs, Medicare, Medicaid, CHIP, and this is a 10-year bill. So it can be revisited at any time, but it'll set policy for a decade. And it can be done on a simple party line vote as long as it's within those guardrails. They also had to do work on the FY26 appropriations process. These are the spending bills that fund everything across the government in discretionary sense, NIH, CDC, the FBI. And then there's mounting pressure on healthcare legislation, even before this most recent election. There's a lot of bills that they needed to pass. They needed to reauthorize the pediatric priority review voucher program at FDA. They needed to pass a bill called Kids Access to Care that lets kids in CHIP and Medicaid see doctors across state lines. All of this is in a normal time, they would just have done it, but they didn't do it. And now it's hanging out there, and the pressure is building for them to get this done, along with a number of other things like PBM reform that they're working on. And then even more recently, they had a government shutdown. The government was shut down for 43 days, longest shutdown ever. Then we had an election. And then we came out of that shutdown because the political mileage had been exhausted. We did that by passing three spending bills, a VA bill, an FDA bill, and the legislative branch bill. So Congress is now funded for the year. They can't not be paid if the government shuts down again. And going on a continuing resolution until January 30th and teeing up the healthcare conversation that's happening right now about cost coverage and out of pockets. The other thing that happened in that election was that Donald Trump was elected the 47th president of the United States. He was already the 45th president. He was the first president since Grover Cleveland to serve two non-consecutive terms. And what it means is we already know a little bit about how the Trump administration operates because we saw it for the 45 administration. And there's a couple of things I'll mention about that. One is there's an awful lot of emphasis placed on executive orders, but every executive order is not created equal. We have free speech in this country. You can walk up to a podium and say whatever you want. It doesn't make it law and it doesn't make it policy. It's completely separate. So an example of that would be you can say, we are going to dismantle the Department of Education, but there's an important line in that executive order. It says, to the extent allowable by law, which means that Congress would have to pass a bill through the House and Senate changing the Department of Education. The administration is very limited in what they can do as the executive branch to do this. Another example would be the changes to indirect cost policy. Some of you might remember that the administration came out in this bevy of executive orders and said, we are going to set indirect costs to 15%. Well, this is an easy one to take in front of the third branch of government, the judiciary, a judge, and say, Judge, they can't do this. And the judge is there to determine if Congress is in its lane or if the administration is in its lane. And in this case, it's cut and dry because in the spending bills that I was mentioning, for the past decade, they've included a line that says Congress sets indirect cost policy and the administration cannot change it. So the administration saying we're changing it, it's very easy for a judge to say, I don't see how you can do this. And the administration lost that case to change the policy, and then they lost on appeal, and then they asked Congress to change it, which they're not inclined to do. But there's a difference between saying you're doing something and actually doing it. And of course, all of this stuff goes to Capitol Hill, to the senators and representatives, and the senators and representatives care a lot more about what you think about something like indirect cost policy than what the administration thinks about it, because you are the ones that they represent. So I want to remind everybody of this dichotomy between what we hear and what is actually going on, and how it is a member-driven process. And the members are driven by you, their constituents, when they make these decisions, and they actively want to hear from you when this stuff is being considered. And I say that because, of course, this is a dynamic environment. And there's been a lot of these. There was the DEI policy, there was the NIH funding freeze. Now there's new rules that were just announced about applying for grants. And I want to make it clear, if you are interested in any of this, or if it seems like, how do you even keep track of it? There's a couple of good resources. The Congressional Black Caucus Foundation has an executive order tracker. If you want to know what the status is of the NIH funding guidance or the DEI funding freeze or the indirect cost policy, you can go to this tool and it will show you, along with all the other proposals that have come out. Is it thrown out of court? Is it held up? Is it implemented? It's an easy way to keep track of some of this stuff in a time when an awful lot is going on. The other thing, of course, was NIH grant termination. So we did see about $750 million in NIH grants terminated. The AAMC has been keeping tabs of this, and I mention that because you've heard a lot about the grants that were canceled, or money that was not going out the door. But put $750 million in context with a $45 billion budget for the NIH overall. A lot of this is business as usual, but of course, it's been a little bit rough around the edges. I will mention one thing is that we've seen the reporting more recently coming out about how money has been missing. NIH has issued fewer grants. There's not as much going out the door. And this is something I assure you Congress is keenly aware of. Congress alone has the power of the purse, the power to spend taxpayer money. If Congress said the NIH is getting $45 billion, then their expectation is that that money went out the door to academic centers across the country and in their states. If a few billion is missing, they want that money to go out regardless, even if it's not the remaining fiscal year anymore. So this was a little bit complicated during the shutdown. but there's an accounting going on of just how much money is not there that was committed, and expect that Congress is going to say, okay, well, we're very interested in the plan to get this outstanding cash out there, because you can't just keep it at the Treasury. It's been spent by Congress via the spending bills, but these are both good resources for keeping track of that. So the first thing that Congress worked on was this partisan budget reconciliation effort, because it could be passed on a simple party line vote. I want to mention again, these are 10-year bills. Usually the implementation of some of the most divisive provisions is delayed, and Congress can revisit them before they go into effect. There were changes to Medicaid, though. They saved money by reducing how generous Medicaid is. There's cost sharing rules with the states, and then there's a lot of work requirements that have been implemented and a lot of eligibility checks, and things like that. Other notable things that occurred was there was a reduction in SNAP benefits, supplemental nutrition assistance. I think everybody nowadays is increasingly sensitive to the linkages between healthcare and health and SNAP and nutrition. The other thing that happened was changes to student loans. So they put in a cap on student loans. A cap on student loans is not a big deal if you're just going to get your bachelor's degree. Cap on student loans is probably a really big deal if you're trying to become a doctor. So this is an issue mainly for those highly skilled professionals. But once again, this provision doesn't go into effect until July of next year. So expect Congress to revisit it and try to get it right. The first thing is kind of a one-size-fits-all solution, and then they work out the kinks as they get closer to implementation. The bill wasn't all bad, though. It did address Medicare physician reimbursement, and it did extend telehealth. And it almost included the Kids Access to Care Act, which is the kids seeing specialists and doctors across state lines bill and Medicaid. And it almost included the Orphan Cures Act, which is the reauthorization of the FDA priority review pediatric voucher program. The other thing that happens is the administration releases a budget request to Congress. And I think this is almost the best way to show how this interaction works between what's going on in the news and what's actually happening on a process standpoint when we engage with our legislators. So when Trump was president 45, he asked Congress every time to cut NIH funding by 20% in his budget. This is a non-binding document. It's called a request because it's just a request. And he said, please reduce NIH by 20%. I don't think the president has any malice towards medical research at all. I think the president simply likes to say, I want to save money. So 20% sounds like a big number. Congress has never implemented this. When he was president 45, of course, there was no 20% cut to NIH. Instead, there was funding increases for NIH. And that's because Congress, Democrats and Republicans, hear from their constituents, and their constituents ask them to increase NIH funding. And that matters more in the process than what the White House is asking for. And the president signed that bill with the NIH increases every time. So this time, the president has asked Congress to cut NIH by 40% and create a bunch of new institutes out of the existing ones. It seems like a nice idea, a good headline grabber, but not real a lot of thought has gone into it. And of course, who would cut research funding by 40% at a time when we're making progress on Alzheimer's and breast cancer and a number of other conditions? Congress responded, and this is a Republican House and Senate, by not doing that at all. Congress has written their spending bills for the year. They increased funding for the VA by $2 million, the VA research program, in that final bill. So the VA bill that was enacted had a $2 million increase for the VA research program. Not the biggest increase ever, but certainly not a cut. And the funding bill for FDA that was enacted increased the FDA by $250 million. So once again, not a cut, a $250 million increase. There are some increases for individual CDC programs, and the House isn't cutting everything. The House has asked for $100 million for new money for Make America Healthy Again activities. They don't want to borrow money from existing programs or take it from one area and move it to another. They preserve HHS, CDC, HRSA, SAMHSA, NIH as they are. No changes to the funding lines or the structure. And they asked for $100 million in new money to create MAHA activities instead of reorganizing everything. The Senate is even more pointed. So, of course, the House, these are Republican-controlled House and Senate. That's the House proposal. The Senate has a $400 million increase for NIH. The House only has 100 million, but still, it's not a cut. The Senate once again preserves everything at NIH, at CDC, at HHS, and it also includes policy riders about how research money is used. It restricts the use of multi-year funding. It says we're not doing the multi-year funding anymore. That was a gimmick and it hurts pay lines. You're not going to be able to do it. It maintains the indirect cost policy and it tells the administration they have to rehire enough staff to run these agencies at NIH, at CDC, as they're supposed to be done and manage their various scientific efforts. So the Senate, in a bipartisan bill, is very pointed. The Senate and House also restore funding for the DoD congressionally directed medical research program. I don't know how many people are familiar with this, but the DoD research program funding got cut in half last year when they went on the CR. The Senate and House both want to fully restore that money to about $1.3 billion annually. So the administration can talk a lot about cuts and reduced resources and fighting with individual institutions, but Congress, through the process of providing funding, is increasing money for NIH and for the VA and for the FDA, not the opposite, and has not reorganized anything. I think that's significant. So, as I just mentioned, the other thing I'll say about completing the Ag FDA bill and the VA bill is that both of these bills come with what they call committee reports. So the House and Senate have instructions that how we want this money to be spent and what we want to have happen. Both the VA bill and the FDA bill bound both sets of instructions. So they said all this is now the law. And that matters because remember, the NIH portion and the HHS bill has these other policy riders about research, banning changes to indirect costs, banning multi-year funding, rehiring staff. So if they follow the same approach for the HHS bill, then all of this will be adopted as well. So things are moving in the right direction, even though they're not there yet. And for the HHS bill, they have till January 30th to finish this process off. So good transition to the next slide. Those three bills are done. The legislative branch, VA and FDA. Everyone else is on what's called the continuing resolution till the 30th, just level funding. What they did when they reopened the CR, you might recall the administration was firing people again when the government was closed. They rehired all of those staff. I'm sure this is quite frustrating to some of these federal employees, but of course, nice that Congress said you're rehiring everyone and you can't furlough any more people or fire them. It did not include the reason that the Democrats held out for to shut the government down, which is this extension of premium tax credits, but promised these votes. And now we have the dueling proposals and new bipartisan work on affordability. And what I'll mention is the Congress is going to go out today, and they're going to do this before they deal with plan year 2026, but they're going to reconvene in January. And much like when the Affordable Care Act got passed, all big thing they're going to be talking about is just what are we going to do about healthcare? There's going to be a lot of stuff happening and a lot of trains leaving the station, and it's going to impact cost. It's going to impact provider work, and it should bode well for increasing public health spending and increasing investment in NIH. But the current pending labor HHS bill, the Senate is proposing $400 million for NIH. The House is not fighting for cuts. It's solely about who gets their increases. The Senate says we want $400 million for NIH. The House says we want $100 million for MAHA. The reality right now is they can both just get that. They're not under a hard cap. They can just each say we're going to take both of these. But the question is politically, where does everyone land? And then, as I mentioned, it would also restore the DoD funding that was cut and likely preserve these policy riders. They may address emerging issues too. So some of you might be aware, NIH recently released this new guidance on how to apply for grants and how grant review is going to work. If Congress doesn't like this or doesn't think it's good for their institutions, they're going to deal with this in the spending bill as well. And of course, there's been implementation of what's called an open access policy for medical journals and how publishing is changing. If Congress doesn't like how that's going or is hearing about problems, they're likely to deal with that in the law as well. But all this is informed by their constituents, the people who tell them about these issues as they work to finalize these bills. The other reason it's good that they may simply adopt these committee reports is that we have really good language about IDEA and CTSA and a lot of other stuff too. Physician training, training grants, full spectrum of medical research. Too much to list on these slides. I only listed two. But the current committee instructions that are pending for adoption include the IDEA program and saying that IDEA networks for clinical and translational research, the CTRs, should be collaborating with the CTSAs better. Everyone's on the same team. Let's share information and maximize our impact. Start breaking down some of these silos, but maintaining our individual resources. And the other is the guidance on CTSAs. Congress very much cares about what they call program integrity. So they maintain the funding line, they provide the money, and then they want to make sure that the hubs are maintained and that the work that they're doing is maintained. Are your core grants preserved? Are you able to do the things you've been able to do? Are you getting all the money you felt was owed to you? And you're supposed to get, they don't deal with the review, who scored meritoriously in their renewal, but they do want to make sure everyone has nearly the same amount of money year over year. So this is very much a focus of Congress and something we hope they continue to maintain through the appropriations process. But they do it because they've heard from so many institutions about why this matters. Encourage you to similarly echo those sentiments. So really quickly before we open it up to questions, just looking forward, Congress is ending their first session now. They will start the second session of the 119th Congress on January 5th. They need to finish off these 9 outstanding funding bills by the 30th. They have the wherewithal to do this, but of course, you want to advocate for those biggest increases possible. There's also emerging talk about the need to reauthorize the NIH. The NIH gets reauthorized about every 5 years. It's time to do that. There's also a discussion about reforming and reauthorizing the CDC. These conversations are largely being led by the bipartisan Senate. The House just isn't participating that much. They're doing their own partisan squabbling. The Senate is trying to work on bipartisan solutions like their bipartisan spending bills, but also in CDC and NIH. They are also working on a bigger, what they call healthcare omnibus from all these issues that have been hanging out there that they haven't gotten done. The Kids Access to Care Act, the Orphan Cures Act, a PBM reform, and 340B reform. They want to try to bundle all this together. If they do that, it will not be until after the November elections next year, and then they'll pass something at the very end of Congress. So there's time to engage with them on what's important from a patient care need. So the other thing to keep an eye on is what the administration continues to do, trying to change indirect cost policy, open access, these other National Science Foundation funding I was just hearing about. Of course, there's a big court fight over ARC, and part of this is where the administration is at, how Congress is responding, and what the court is ruling on a lot of these decisions, which in many cases is them saying the administration is out of line and they can't do what they're trying to do. And then Congress, of course, through the normal legislative process, is providing some type of moderate policy update. And then we do expect healthcare and spending and the spending bills to be the major focus of Congress. And then they're going to have a midterm election in November, and they're going to come back and they're going to finish off their work. But they are keenly aware of what their constituents are saying, what people are feeling. And once again, if you see challenges or opportunities, it's important that you explain those to the health LAs in your senators and representatives' offices. And of course, we hope you'll join the CCTS on bigger initiatives to simply flag the importance of NIH funding overall, CTSA funding, IDEA program funding, and answering that age-old question on the Hill. What is clinical and translational research even? If some of you don't know the joke I'm making, if you've ever been to the Hill, the staffers are all very, very young. They're right out of college, and they very much appreciate it when people who are technical subject matter experts and have lots of initials after their name can give them honest, accurate information that informs how they should be allocating resources and making policy decisions. It's a tall order for them. It's very much more practical for you, and your lived experiences help them make those decisions. So please make your voice heard. And if there's ever a time when it's a dynamic environment, it means you should be reaching out, because you certainly don't want them making decisions without your input that might affect you. So thank you very much. I will once again remind everybody, I have never personally applied for a grant. I am not a scientist. I just know the policy side of this and the government side. So Some of the more nuanced or focused questions I might struggle with, but broader questions about what's happening in Washington or advocacy, very happy to help answer. And I very much appreciate everybody's time today. Thank you.
Well, thank you so much, Dane. That was a great talk. We do have time for questions, so you either can unmute or put your questions in the chat.
And I'll drop the screen share so we can all see each other a little more easily. Sarah, was that a wave or a hand up?
I have a
Oh,
question. This is Darcy Friedman. I'm a professor of population quantitative health sciences at Case. I guess I have, and you may not be able to answer these questions, but one is around, I'm going to say both of them and then you can answer. One is around, I thought it was interesting your comment that these funds for grants were made available by Congress or allocated, and then even if they haven't been expended, and kind of talking a little bit more around timelines to use up those funds and just for us to be thinking about those dollars are available. And then secondly, there's been a lot of kind of censoring, I guess, I don't know if that's the right word, of words in the work that we're doing. And I was just curious if that's something we should be continuing to be focused on, and like how we frame the work we're doing, if there's right words or wrong words, and just either of those two areas would be helpful to hear your thoughts.
yeah, and I do believe I have a couple of good answers. I will mention I know that the Q&A session isn't always recorded, so I'll give a brief pause if this is a different thing, but 3, 2, 1. Okay. So first and foremost, money allocated by Congress and timelines. Yes. So not to get too far into the weeds here, but the administration made a lot of political noise by touting this idea of sequestration, that Congress can allocate money. So of course, we have three separate co-equal branches of government. The only one that has the ability to spend taxpayer money is the Congress. So Secretary Kennedy has his own like 1% discretionary budget, but he's given that by Congress. He doesn't have it because he thinks he has it. And he couldn't say, we need to study the link between ultra processed foods and autism. I'm starting a $500 million fund to do this. He cannot, only Congress could do such a thing. So just so people understand the interplay here between kind of the Constitution. So Article 1, only Congress can provide money. And of course, for the NIH, it's one thing to say CTSAs are getting 629 million, but normally they just say the NHLBI is getting $3.5 billion. Spend it on the heart, lung, and blood, you smart people, where the best investigator initiated research is. The dichotomy that emerges with the sequestration issue is that the White House does not have the right to not spend that $3.5 billion at NHLBI. They can't say, well, you gave us 3.5 billion, but we only issued 1 billion in grants. We just kept the other two. The money has to be drawn from the Treasury. So, and of course, if you're no matter if you're a Democrat or a Republican, if it's NIH money or CDC money, if you are Shelley Moore Capito, the senator from West Virginia, who is the Labor HHS Appropriations Subcommittee chair, you expect the Public Health Department in West Virginia to get all the money coming to them from the CDC. And you expect WVU to get all the money that is coming to it from the NIH. So by and large, this system worked as it always has, but of course, in the margins, money is missing. Half the money isn't missing, but it's a few hundred million here and a few billion there. And some of it is, you're right, if you canceled $750 million of DEI grants, then you should be issuing NOFOs and supplemental funding opportunities to get that money back out the door because it's been committed. Part of the problem was not this administration belief that they don't have to spend it. The court, I think, would deal with that because this is like an arcane idea from the Civil War. It has to do if you're withholding money from a country that you might end up declaring war on. It has nothing to do with funding research or anything. So, but the problem was they set up this whole new system, remember, for peer review and getting funding committed. And it didn't work like they thought it would. It was much more cumbersome. It was much harder to get things done. Then they fired staff who would normally help get the grants out. And then the government shut down for 43 days. So this was all very frustrating for Congress. But the message from the appropriators, and this is usually a behind the scenes message from Republican senators to the White House, is okay, we'll give you a mulligan on FY25, not being able to get everything done. But if you didn't spend all the NHLBI money, tell us what your plan is to get the rest of it out the door, even as you're getting FY26 committed. This is a bit of an accommodation. You wouldn't normally do this, but they want the money spent. And so we're expecting these notices to start coming out, or the supplements to start coming out as the process has gotten back to normal. And we're seeing regular advisory council meetings and everything else. The other thing, they know the money is missing. They're trying to tally up how much, and they expect it'll all be spent eventually. So likely probably additional money during this fiscal year when that bill is finished, plus the money that wasn't completely out the door last time. In terms of framing, I don't want to, I want to give an honest, objective, and direct answer devoid of politics. So I will say this, the Health and Medicine Council has worked with, has a large portfolio going back to the 70s, working with the historically Black colleges and universities. And if you are Morehouse in Atlanta, or if you are Meharry in Tennessee, or if you are in Alabama, this idea of censored words and what you can and cannot say is not new to you. You have dealt with this with the Louisiana legislator. You've dealt with it with the Alabama legislator. You've dealt with it with the Tennessee legislator. It has only now come to the national conversation. And the sad reality is a lot of times this is just optics. The members want this money to go to their district. They just don't want projects framed a certain way. So if you talk about it using different language, the exact same thing can get done as long as it's not on a publicly facing website that says we're studying X, Y, or Z. So NCATS, to their credit, was very good about working with folks to reframe their submissions, and this process was successful. And of course, moving forward, they're going to continue to have these word searches at the executive level to disqualify grants. And we've heard all the, using certain words that might have a D, E, or I in them, or, the trans fat study getting canned for no reason other than some algorithm said it could be a problem. So do not expect a high level of nuance from the administration on this. But unfortunately, there's two ways to deal with this. One is an interim solution, which is just play the game and get the money using the system that's presented to you. The other is a political one, which is if you don't like what's happened and you disagree with it, then that's why you vote, So go vote on that when you get the opportunity. And I say that because I know a lot of people would say I have a personally, I have a strong belief that I shouldn't be censoring myself. But the reality is, in the current system, there really isn't a path to get around that other than going to the ballot box and saying, I don't agree with this, so I'm going to vote for a different Congress. And that Congress is going to put much tougher safeguards in place that protect the kind of work that I'm trying to do. But there isn't a way to really do that with NIH or the administration. Lillian.
Hi, Dane. Thanks for the presentation. Appreciate it. Especially mentioning Robert Wood Johnson. I am a former fellow. I've been hearing, I think in some ways we are in unprecedented times, and I really appreciate your optimistic view. It did help calm me down a little bit. But we have seen the current administration push harder on these kind of like foundations and things that we have taken for granted for a long time to see what sticks and what doesn't. And as things move through the Supreme Court, through the courts, all the way up to the Supreme Court, there's been kind of a mixed bag in terms of how things are happening. And Congress, in many issues, have decided not to exercise its rights right, in many of these issues. And one thing that I hear a lot that is a likely outcome of all of this is that things are going to change. We're going to be coming into a new normal. And I was curious about your perspectives in terms of like what are some of the things that are likely to have already changed and not likely to go back to the way that it used to. And one example perhaps would be, say, with IDC funding, right? I know that there's been always a pull and tug in terms of what that looks like. From what I hear, it sounds like that is very likely to be changing. What are some of the things that you are hearing about, and how would you anticipate this changing?
Yeah, so I would agree with you that there is new pressure on what you think of as kind of foundational issues. And one of the things that the CCTS would have to navigate, of course, is it's one thing to say we want to make sure that the CTSA hubs do not lose their funding using the enhanced line item protection. And we were very good about that. There isn't a CTSA that lost its NIH grant, even though there were many that said, I am doing a lot of work in X, Y, or Z area. And I think that was a credit to kind of NCATS being proactive, but also the fact that there is these enhanced protections. But of course, that's not the same thing on a policy level. If you are Northwestern and you have decided, or Harvard, and you have decided you are going to fence with the administration in court over the concept of federal funding in general. And each of these institutions adopted their own strategy for pushing back against this pressure. Some signed the compact, some said, like Harvard said, we'll see you in court. And it's really their prerogative for how they approach that. But you're right, it reflects an unusual pressure. We would respond to that pressure with things like very discreetly in the law or in that CTSA language, making sure that PIs were protected or that young investigators or training grants were protected. And that's similar to how some of these issues have been dispensed with. One of the biggest champions of the community has been Katie Britt from Alabama. She's a Republican senator who worked for Shelby, who helped like establish the CTSA program. She would never go in front of a podium and say, I hate what the White House is doing, but she would absolutely write a spending bill that puts guardrails in the law that doesn't allow them to exert, some of these pressures on academic institutions or research. There would never be a big deal made out of it. There's no 60 Minutes story, but that's how that would be dispensed with. And about things that are unlikely to change, one thing I would point out is, the pendulum swings and the pendulum swings back. So in a couple years, we're in an anti-science moment right now, distrust of government, distrust of, people who are very smart. Everything is a conspiracy. That will shift back, and then people will be saying, doctor, please tell me, how to make myself healthier. But Congress is going to say things like, we had these problems with research. Now, how are we going to invest in getting young investigators into the pipeline since we've alienated? Do we need $500 million? We need $1 billion? That will shift back, and we'll want to capitalize on those opportunities. Congress will have money to spend, but they'll say, where should this go to fix science and bring people back from Canada, for example? That's different from a policy like indirect costs, where there was a sense that its time had come. People had felt that IDC was kind of like lingering out there and needed to be dealt with. The problem for the administration was they took a very aggressive stance and said 15%. And then folks said impossible. So, but they're working on it. But Congress, remember, works on geologic time. So it might not be the FAIR model. It might be some permutation of the FAIR model. You don't usually want to say no. You want to say, well, let's find a reasonable solution. Or is there a compromise? They're working on that now. This is tough, though, because the solution they come up with conceivably would have to enfranchise a wealthy Northeastern, high cost of living Ivy League school the same way it would enfranchise the University of Illinois or the University of Utah. So the complication for Congress, it's easy for the administration, but for Congress, it's hard to come up with an IDC model where everybody believes they're being treated fairly just because of the diversity of how all of that works. But this will, I think, be a longer process than just right now. But the one thing with the Supreme Court is if they're going to give all of these powers to the executive, then when a Democratic president gets elected, they're going to exercise them in a different way. So it's tough to see how it's going to start shifting back and forth, but it will. But something like IDC, Congress will take thoughtful, probably lengthy deliberation to come. They won't just rush it for the sake of doing it. But I do know we're at the top of the hour, but I want to thank everybody again for the thoughtful questions and the time today.
Great. Well, thank you so much. I am just going to pop up 2 slides quickly. This one is for claiming CME credit. If you don't have time or you don't have your phone handy, that's okay. You'll also receive this all in an email with the directions and then the code as well. And the last thing is the QR code on the left is for you to register for the upcoming sessions of the Distinguished Speaker Series. So next month will be Dr. Santola on January 29th at noon. And then the right QR code is if you're not already a member of the CTSC, make sure to sign up so you can stay up to date with all of our upcoming events. So that is all I have. And thank you, everyone, and have a wonderful rest of your day.